Hello, my name is Danielle Spada, and this is Case Study Part 3, where we will continue to focus on Client P. During this presentation, I will first review Client P. Next, I will discuss Client P's problem behavior, mouthing. I will then discuss the intervention used to treat mouthing. Next, I will discuss staff training methodology. Then I will first cover how treatment validity has been measured, as well as how treatment integrity could be measured in the future. Client P is a 4-year-old diagnosed with autism. He is considered to be vocal nonverbal. Client P attends a specialized preschool full-time and receives 40 hours of direct behavioral services per week. Both the Verbal Behavior Milestones Assessment and Placement Program and a Functional Behavior Assessment were used for Client P. One of Client P's problematic behaviors was mouthing. The operational definition of mouthing is any instance of placing objects in the mouth that are not intended for chewing or biting. Examples included biting toys, licking the floor, and biting clothes. Non-examples included biting on a chewy, eating food, and drinking from a straw. The perceived function from the FBA was automatic reinforcement or sensory. The intervention utilized to decrease mouthing was response interruption redirection. The intervention procedure was that if Client P started to engage in inappropriate mouthing, he was to be immediately redirected to use his designated chewing item, which we referred to as a chewy. Social praise was then used to reinforce the use of the chewy. Regarding functional relevance, the perceived function of mouthing was automatic reinforcement or sensory. The replacement behavior was chewing on the designated chewing item. The replacement behavior satisfied Client P's sensory seeking. In other words, the replacement behavior function appropriately matched the problem behavior function. Client P was taught to achieve automatic reinforcement in a more socially acceptable way. Staff training methodology consisted of behavior skills training. The steps included describing the skills to be trained, along with the rationale for the importance of the skills, modeling the target skill for staff, having staff practice performing the skills with feedback, and repeating staff demonstration of skills until competence is achieved. For the staff working directly with Client P, the skill taught with response interruption and redirection. Training was achieved during overlapping sessions with the BCBA and RBTs. Each RBT was trained one-on-one during their scheduled shift with Client P. The RBT was provided with Client P's data sheet, which described the goal, that Client P will decrease inappropriate mouthing and increase his use of designated chewing items. The RBT was prompted to review the intervention summary on the data sheet and to ask any questions. Next, the BCBA modeled implementation of response interruption and redirection during a naturally occurring incident of Client P engaging in inappropriate mouthing. Role play between the BCBA and RBT followed, consisting of the BCBA pretending to engage in inappropriate mouthing and the RBT interrupting the behavior by presenting the designated chewing item directly in front of the BCBA's mouth, along with vocally labeling the item chewy. The RBT also practiced recording frequency data for both inappropriate mouthing and the use of the chewy on the data sheet. This was practiced until the RBT demonstrated 100% procedural accuracy. The BCBA reviewed where in the classroom the RBT could find additional designated chewing items, along with where to store the chewing items when they were not in use. Also, the BCBA prompted the RBT for questions during the initial training and during successive overlapping sessions. There is an additional component to staff training that was not included, but could be included in future trainings. After target skills are described, along with the rationale for the importance of the skills, a written summary of the skills could be given to staff. This could take the form of a checklist. For Client P's treatment, a summary of the intervention was provided on the data sheet, but it was not provided in the form of a checklist, which would make for easier trainee comprehension. Treatment validity measures whether the treatment choice is appropriate and aligns with the goals of the client. To date, high treatment validity has been reported for the use of response interruption and redirection for Client P's mouthing. For Client P, treatment validity was measured in 4 ways. One way was through stakeholder collaboration during goal setting. Client P's parents and teachers were made a part of the goal creation process. During this time, stakeholders expressed the safety concerns of Client P's inappropriate mouthing in the school setting. This led the supervisor to target this problematic behavior for intervention. Another intervention validity measurement was achieved through continual monitoring of the behavior change intervention. Visual analysis is conducted regularly for client P's frequency of inappropriate mouthing, as well as his frequency of mouthing designated chewing items. As of current, client P's data show a decreased trend for inappropriate mouthing and an increased trend for mouthing designated chewing items. The data suggests the intervention is proving to be effective, which is decreasing the risk of client P sustaining injury in the school setting. Stakeholder feedback has also been a successful means of measuring treatment validity. Client P's parents and teachers have been asked if they have noticed a positive change in client P's behavior, as well as that they believe the intervention is still necessary. Lastly, quarterly surveys have been completed by client P's parents. While these surveys do not target the mouthing intervention alone, they have been used to get a reading of how acceptable the behavior services have been. Answers were provided using a rating scale, with 1 representing least pleased with services and 4 representing most pleased with services. All of client P's quarterly parent surveys to date have come back with all 4 ratings in every category, indicating that his parents are finding the services to be socially valid. Treatment integrity is a measurement of the degree to which an intervention is implemented as planned. There is no current measurement of treatment integrity for the intervention targeting client P's mouthing. Efficient measurement can be best achieved with performance checklists. A performance checklist is a written listing of all key actions necessary to perform a certain duty. In this example, it lists the duties required to successfully implement response interruption and redirection. Treatment integrity can be measured through direct observation while using a performance checklist. The supervisor will check off each step of the checklist as they observe the supervisee completing them. Direct observation can be conducted overtly, when the staff are made aware of the performance being monitored, or covertly, without the staff knowing that they're being monitored. Covert monitoring can reduce staff reactivity, but it can also decrease training acceptability. Overt monitoring is therefore recommended. Self-monitoring is another means of measuring treatment integrity. This consists of the staff recording successful implementation of each step of the intervention using the performance checklist. This data can be collected during or after programming is complete. This method can help reinforce what the supervisor taught during the direct observation sessions and prevent procedural drift. In the future, it is recommended the client P's intervention programming be converted into performance checklist. Direct, overt observation should be conducted to review staff performance and programming, with the emphasis on providing staff with informal, positive vocal feedback when the intervention steps are being implemented correctly and consistently. This is to occur during normally scheduled overlapping sessions with supervisor and supervisee. Self-monitoring is also recommended. The performance checklist for the intervention will be kept in the client's binder so that staff can review it during each session to prevent procedural drift. In conclusion, client P is a 4-year-old with autism. Mouthing is a problematic behavior. An FBA found that the function of mouthing was automatic reinforcement or sensory. Response interruption and redirection was selected to decrease inappropriate mouthing and increase mouthing of designated items. High treatment validity has been found for the intervention targeting client P's mouthing. A performance checklist will be used to monitor future treatment integrity through direct observation and self-monitoring. Thanks for watching.